This test consists of 3 parts: Part A, Part B, and Part C.
Part A. You will listen to 2 separate health professional patient consultations extracts. There is a total of 24 questions. For Extract 1, there are 1 to 12 questions. For Extract 2, there are 13 to 24 questions. For questions 1 to 24, complete the notes with the information you hear. At the start of each extract, you will hear a beep sound.
Extract 1. Questions 1 to 12. Look at the notes for Extract 1. You hear a physician talking to a patient called Mr. James Williams. Complete the notes with the information you hear. You have to
Hello, doctor. Good morning.
Good morning. What's your problem?
Well, he's my father, and he had a septic shock. And when we consulted locally, the diagnosis revealed elevated cardiac enzyme profile. He had some workup done from cardiac standpoint, which has been negative so far.
Okay. Does he have any previous history of chest pain or shortness of breath?
No, doctor.
What is his name and age?
His name is James Williams, and he's 58 years old, doctor.
Does he have any history of hypertension or diabetes mellitus?
No, doctor.
Does he smoke or drink?
No, doctor.
May I know his past medical history?
Well, he had pulmonary fibrosis, and he is on prednisone. Oxygen-dependent cellulitis, status post-foot surgery with infection, recuperating from the same. Respiratory acidosis, septicemia, and septic shock. Presently on mechanical ventilation. No prior cardiac history. Elevated cardiac enzyme profile.
He had any surgery earlier?
Yes, he had foot surgery.
Okay. What medicines he is taking now?
Vitamin supplementation, prednisone, cyclobenzaprine, losartan 50 mg daily, nifedipine 90 mg daily, Lasix, potassium supplementation.
Is he allergic to any medicine?
Yes, he's allergic to sulfa.
Well, his physical examination reports show pulse rate of 94, blood pressure of 98/57, respiratory rate as normal, air entry bilaterally clear, rails are scattered, point of maximal impulse displaced, S1, S2 regular, systolic murmur grade 2 of 6. There are chronic skin changes, markings in the lower extremities. Pulses found palpable. His laboratory reports show echocardiogram is normal, sinus rhythm with wide complex, white blood count of 20,000, hemoglobin 10, and hematocrit 33, platelets of 163, international normalized ratio 1.36, BUN of 158, creatinine 8.7, potassium 7.3 of bicarbonate is 11, cardiac enzyme profile, troponin, 0.05, total creatine kinase, 312, myoglobin, 1423, chest x-ray, no acute changes. He has pulmonary fibrosis and is on prednisone, oxygen-dependent with respiratory acidosis, septicemia, septic shock secondary to cellulitis of the leg, acute renal shutdown, elevated cardiac enzyme profile without prior cardiac history, possibly due to sepsis and also failure. I am ordering an echocardiogram to assess left ventricle function to rule out any cardiac valvular involvement. He needs aggressive medical management, including dialysis. From a cardiac standpoint, conservative treatment at this juncture. His cardiac enzyme profile could be elevated secondary to sepsis and also underlying
Extract 2, questions 13 to 24. Look at the notes for Extract 2. You hear a consultant dermatologist talking to a patient called Jake Venter. Complete the notes with the information you hear. You have to write down a word or a phrase. You will get 30 seconds to look at the notes.
Jake Venter? Please come in and take a seat.
Thanks.
Okay, now I understand from your GP that you've got a problem with your hand?
Yes, I went to see you a couple of weeks ago because of a sore on my left hand. I've had it for years, but not all the while. You know, it appears, then it gets better, then it comes back. It's here on the palm. It's almost gone now. But she wasn't sure what it was, so she said I'd better see a dermatologist. She took a photo. Did you get that?
I did, yes. So tell me about the condition, how it feels and...
Well, I always know when I'm going to get it because I have this itching beforehand.
Right.
I wake up at night wanting to scratch the area, though I try to stop myself.
Good.
Then a few hours later, I get one or two little blisters, and they gradually get bigger and join up into one big one. It all feels a bit hot, and the skin around it goes red. When I showed this to the doctor, she used the word chaotic to describe it. Anyway, it gradually dries up, and I get a scab. Then after about 2 weeks, that falls off and there's just a little red patch, like you can see now.
Okay.
I've been getting it for years. I actually got it the first time when I was in China in the 1990s. I had a job there for a couple of years before I came back here. That first time, I also had a similar sore on my chest, but that's never come back. But the one on my hand, that comes back every year or so, but never in exactly the same place. I thought it had sorted itself out because I didn't get it for a couple of years, but then it came back.
Right.
So there's no pattern. It's not getting more frequent or anything, and it doesn't seem linked to anything in my daily life. Like it doesn't seem to happen when I'm run down, for example, or because of anything in my diet, or if I'm under a lot of pressure at work, that kind of thing.
Okay.
So the doctor thought you needed to have a look. Also because I had a melanoma on my back that was removed in 2006.
Right.
It was at quite an early stage and it hadn't got too deep.
Okay, well, that's good. Still, I'll just have a look at your back.
Mm-hmm.
Was it down here?
Yeah, that's right.
Okay. Well, yeah, that all looks absolutely fine. Well, I don't think you need to worry about anything sinister here. By the way, have you ever had cold sores?
No, never. But I did wonder if this thing on my hand was something like that. In fact, I wanted to ask you about that. There's an antiviral cream you can use, isn't there, to stop them developing? I wondered if you could prescribe me something like that.
Look, the trouble is these work well on the mouth because the skin's very thin there, but I'm afraid they won't have any effect in your case because the skin on your hand's so much thicker.
Oh, I see. Well, something else that worries me is whether there's a chance of infection. Should I be covering the place up?
No, you don't need to unless there's broken skin.
Right, good.
It's fine.
And it's not actually having an impact on my quality of life or anything like that. It's something I can live with. I mean, I have done for all these years.
Okay, so really the reason you went to the doctor after all these years was just to see if there was any way we could prevent this happening.
Yeah.
Okay, well, at this stage, the best thing to do is organise a biopsy. It might be a bit uncomfortable, but it means we can rule certain things out.
Okay.
Part B. You will listen to 6 short workplace extracts. For each extract, you will get one multiple-choice question, A, B, or C. For questions 25 to 30, choose the answer A, B, or C which fits best according to what you hear. You will get 15 seconds to read each question before you listen to the extract. At the start of each extract, you will hear a beep sound.
Question 25. You hear 2 radiologists talking about the type of scan to be given to a patient. You will get 15 seconds to read the question with options.
I've just had a phone call from emergency. They have an 11-year-old boy with right lower quadrant abdominal pain. They're concerned about appendicitis and they'd like to order an abdominal CT for him.
Do you think that's a good idea?
I was thinking maybe we should recommend an abdominal ultrasound because then we can spare him the radiation.
Is there any concern in this case around using ultrasound instead of CT? Accuracy, for example.
The sensitivity is slightly less than the CT, but the specificity is almost the same, so I think we can rely on the results.
Okay. It means we can avoid the child being subject to contrast exposure as well. But what would we do if the ultrasound doesn't answer the question?
If we can't visualise the complete appendix, then we can recommend an abdominal CT.
Okay, we have a plan. Call them back and let them know.
Question 26. You hear part of a surgical team's briefing. You will get 15 seconds to read the question with options.
Okay, next is Mr. Malloy's repeat laparotomy. Any anaesthesia issues?
We don't expect any particular problems. He's relatively fit and well, except for his epilepsy, which is under good control. His BMI is 35.
But will we need the obesity bed?
It shouldn't be an issue.
And what about the epilepsy post-operative management?
He's taking his oral medications and we can use an IV if necessary.
I know he was in a lot of discomfort after his last surgery, and this time he's going to need a larger midline incision. It may be worth thinking about an epidural. He's certainly at the extremely low edge in terms of pain threshold.
Question 27. You hear a senior research associate talking about a proposal to introduce interprofessional primary healthcare teams. You will get 15 seconds to read the question with options.
We're looking at opportunities to improve the effectiveness of health and healthcare systems here in Canada. One of the interventions we're looking at is interprofessional primary care teams, groups of professionals working together collaboratively to provide services including healthcare, social services, and advice to patients within the primary care setting. There's evidence that teams like these can improve chronic disease outcomes, including diabetes, hypertension, and heart disease, as well as mental health problems. There's also evidence that improvements can be made in terms of both access to and coordination of care. Now, the extent to which these teams could affect the costs of healthcare in such areas isn't quite clear within the evidence, but the work we're doing aims to address such issues while looking at the challenges of implementation and evaluation.
Question 28. You hear a discussion between a nurse and a physician explaining different types of breath sounds. You will get 15 seconds to read the question with options.
Hello, doctor. Can you explain what are the different types of breath sounds?
Well, there are several distinct types of abnormal breath sounds. Crackles, also called rails, tend to sound like discontinuous clicking. Bubbling or rattling when the person inhales. Crackling breath sounds may sound dry or wet, and physicians might describe them as either coarse or fine. Stridor is a high-pitched, harsh, wheeze-like sound that occurs while breathing in people with a blocked upper airway. Wheezing noises are high-pitched and persistent that may sound like a breathy whistle. At times, wheezing can be loud enough to hear even without a stethoscope. A short version of a wheeze, called a squawk, occurs during inhalation. Ronchi are persistent, lower-pitched, rough sounds similar to snoring.
Question 29. You hear a discussion between a nurse and a physician explaining surgical treatments for patients with a desiccated disc. You will get 15 seconds to read the question with options.
Hello, doctor. What are the surgical treatments for patients with a desiccated disc?
There are many different surgical treatments for a desiccated disc. In the method called fusion, the vertebrae surrounding the desiccated disc will be joined together to stabilize the back and prevent movement that will worsen pain, causing discomfort. In the decompression method, the extra bone or a disc material that has moved out of place is removed to make more room for the spinal nerves. In the correction method, the surgeon will make the necessary repairs to correct an abnormal curvature of the spine to relieve pain and increase range of motion. In the implant method, artificial discs, or spacers, will be placed in between vertebrae to prevent the bones from rubbing.
Question 30. You hear a monologue by a physician explaining Heberden's nodes. You will get 15 seconds to read the question with options.
The bony growths that develop on the finger joints are called Heberden's nodes, or interphalangeal joints. Mostly, Heberden's nodes develop on the joints nearest to the fingertips, causing the fingers to appear crooked. They only develop in osteoarthritis patients. Each joint in our body has a layer of cartilage to protect the bones. Osteoarthritis causes the cartilage layer to degrade, gradually allowing the bones in the joints contact directly with each other. Over time, the bones get damaged from scraping together. Our body reacts to this body damage by developing new bones that are known as nodes. Heberden's nodes are one of such bone formations on the fingers of patients with severe osteoarthritis.
Part C. You will hear two different extracts. In each extract, you will hear health professionals talking about specific aspects of their work. For questions 31 to 42, choose the answer A. B, or C, which fits best according to what you hear? Complete the answers as you listen to the audio. At the start of each extract, you will hear a beep sound. Now, look at the extract 1.
Extract 1, questions 31 to 36. You hear the lecture given by a physician on the topic of cystic hygromas. You have 90 seconds 1:30 minutes to read questions 31 to 36.
Amyotrophic lateral sclerosis is a kind of motor neuron disease referring to a group of progressive neurological diseases that cause dysfunction in the nerves that control muscle movement, resulting in muscle weaknesses and changes our body functioning. The advanced stages of amyotrophic lateral sclerosis affects the nerves that control breathing, resulting in mortality. Amyotrophic lateral sclerosis is sometimes called Lou Gehrig's disease, after the famous baseball player who was diagnosed with this condition. Upper motor neuron symptoms include resistance to movement in the muscles and brisk reflexes and stiffness. Lower motor neuron symptoms include muscle atrophy, weakness, and twitching. The lifespan of the patients with amyotrophic lateral sclerosis is about 3 to 5 years after the appearance of the symptoms. Presently, there is no cure for lateral sclerosis, and treatment is aimed to relieve symptoms, to provide emotional and social support, and to slow down the progression of the disease. Amyotrophic lateral sclerosis attacks the nerve cells used in voluntary muscle actions called motor neurons. Motor neurons are found in the spinal cord and in the brain. As amyotrophic lateral sclerosis progresses, motor neuron cells degenerate and die. Therefore, they stop sending messages to muscles for performing actions. At this stage, the brain can no longer control voluntary movement, and the muscles gradually weaken and waste away. As amyotrophic lateral sclerosis progresses, it affects all the voluntary muscles, where the patient can no longer control their face, arms, and legs. At this stage, inability to breathe results in respiratory failure. 50% of the patients with amyotrophic lateral sclerosis will live for 3 years or more after the diagnosis. However, some patients live for longer. About 20% of patients will live 5 years or more after diagnosis, while just 10% of the patients will live for 10 years or more, and 5% of patients will live for 20 years. There are different types of amyotrophic lateral sclerosis, classified based on their signs and symptoms and with a genetic association. Amyotrophic lateral sclerosis can be sporadic or familial. Sporadic amyotrophic lateral sclerosis occurs randomly, and it accounts for 90 to 95% of patients. There is no clear risk factor or cause. About 5 to 10% of patients are with inherited amyotrophic lateral sclerosis. The offspring of a patient with amyotrophic lateral sclerosis will have a 50% chance of developing a similar condition. Disorganized immune response is also a cause for amyotrophic lateral sclerosis. the immune system may attack the cells of the body, possibly killing nerve cells. Chemical imbalance is another cause for amyotrophic lateral sclerosis, where the patients often have higher levels of glutamate secretion, a chemical messenger in the brain near the motor neurons. Higher levels of glutamate is known to be toxic to nerve cells. Missed proteins can also cause amyotrophic lateral sclerosis, when body proteins are not processed appropriately by the nerve cells. Hence, abnormal proteins potentially accumulate and cause nerve cells to die. The symptoms of amyotrophic lateral sclerosis usually start appearing in late 50s or early 60s. However, symptoms can appear at other ages as well. Progression of the disease will vary between patients. Common symptoms include difficulty carrying out daily activities including walking, increased clumsiness, weakness in the feet, hands, legs, and ankles, cramping and twitching in the arms, shoulders, or tongue, difficulty maintaining good posture and holding the head up, uncontrolled outbursts of laughing or crying, known as emotional lability, cognitive changes, slurring of speech and difficulty with voice projection, pain, fatigue, problems with saliva and mucus, and difficulty breathing and swallowing in the later stages. Early symptoms of the disease often include abnormal limb fatigue, clumsiness, slurred speech, and muscle cramps and twitches. Symptoms will spread all over the body as the disease advances. No single test can diagnose amyotrophic lateral sclerosis, so diagnosis is based on test results and symptoms to rule out other possible conditions with similar symptoms. The diagnosis of amyotrophic lateral sclerosis are made through electromyography to detect electrical energy in the muscles and nerve conduction studies to test the significance of the nerve signals. These diagnosis methods can help rule out peripheral nerve damage or peripheral neuropathy and muscle disease called myopathy. Certain medical conditions that produce similar symptoms to amyotrophic lateral sclerosis include Lyme disease, multiple sclerosis, HIV, West Nile virus, and the poliovirus. Amyotrophic lateral sclerosis is confirmed in case there are symptoms in both the lower and upper motor neurons. Upper motor neuron symptoms include resistance to movement in the muscles and brisk reflexes and stiffness. Lower motor neuron symptoms include
Extract 2, questions 37 to 42. You'll hear health professionals talking about aspects of their work. You have 90 seconds, 130 minutes to read questions 37 to 42.
My name's Sandra Morton, and I'm a specialist cancer nurse, helping cancer patients deal with their diagnosis and treatment. I'd like to tell you about the type of work I do, and particularly about one of my patients, recently diagnosed with prostate cancer. Let's call him Harry, to illustrate the sort of things I get involved with. Now, before we get on to Harry, I'll give you a bit of background. Clearly, my job covers many aspects of patient care, but what's the priority? Firstly, prostate cancer is the most common cancer in men in the UK, with over 40,000 new cases diagnosed every year. That's a staggering number. One problem is that this type of cancer actually develops very slowly, so there may be absolutely no sign that you have it for years. So, if we're going to reduce the number of cases, it's vital that people like me get the word out to as many men as possible, that we tell them how to spot the signs of prostate cancer, like an increased need to urinate or straining while urinating. Unfortunately, the cancer can be at an advanced stage by the time patients come in for tests, at which point the available treatments are far less effective. So, let me tell you a bit more about my patient Harry. Like many middle-aged men, Harry was offered a routine health check at his local doctor's surgery. As far as he was concerned, he had no particular health problems or obvious symptoms at the time, and so he almost ignored the invitation. But he'd promised his family he'd look after himself. His wife had died of ovarian cancer some years before, so he felt obliged to go. It was during his appointment that, based on a few symptoms he mentioned, Harry's doctor decided that he'd need further investigation for prostate cancer and referred him to a specialist clinic at the hospital.